So I'm going to go ahead. I have the pleasure of introducing Dr. Cynthia Rogers, who is the Blanche F. Edelson Professor of Psychiatry and Pediatrics at Washington University in St. Louis and Director of the Division of Child and Adolescent Psychiatry. Dr. Rogers graduated with a BA in psychology from Harvard University and completed her MD in psychiatry residency and child and adolescent psychiatry fellowship at Washington University. She's an academic child psychiatrist. You're a unicorn. Thank you for doing what you do. Whose program of research focuses on improving the psychiatric outcomes of infants through understanding the underlying neural mechanisms of social, emotional development and psychopathology, and the impact of social determinants of health on these mechanisms. Dr. Rogers co-directs the Washington University Neonatal Development Research Wonder Group, a multidisciplinary lab which uses multimodal MRI to understand how poverty, racism, prematurity, and prenatal substance exposure affect the brain at birth, alter brain development across childhood, and relate to child psychiatric disorders. Dr. Rogers serves as a principal investigator of multiple NIMH and NIDA funded longitudinal research studies, and serves as associate director of the Healthy Brain and Child Development National Consortium Study. Dr. Rogers' clinical work centers on addressing the impact of social determinants of health to reduce development of psychiatric disorders in perinatal and child populations. She co-directs the Washington University Perinatal Behavioral Health Service, which serves perinatal women with psychiatric and substance use disorders. And she leads a teaching consultation clinic for formerly preterm children with early developmental and socio-emotional delays. She serves on the editorial board of Biological Psychiatry and is deputy editor of the Journal of the American Academy of Child and Adolescent Psychiatry. She's also a member of several professional societies, including the American Academy of Child and Adolescent Psychiatry, the Flux Society, and the American College of Neuropsychopharmacology. It's such a pleasure to have you here. And I'm going to go ahead and pass the mic to you, Dr. Rogers. Please join me in a warm welcome. If you could hear us clapping, we are.
Thank you so much. It's a pleasure to be here with you all today. Thank you for that wonderful introduction. I'm going to share my slides. Please let me know if you all see that. Does everyone see that okay? Fantastic. All right. So yes, I'm Cynthia Rogers. I'm going to talk to you all today about a lot of the work that we do that focuses on social determinants of health and how we can address those to optimize infant brain development. So my disclosures. All right, so the goal today is to just review social determinants of health, although I know I'm sure many of you are aware of these factors, and then talk about how social determinants interact with brain development, and then how we are attempting to address some of these social determinants here at WashU. So this graphic here just denotes some of the different categories that we think of when we think of the social determinants of health. And the thing that I think is becoming increasingly known and very vital for us is the fact that these account for 75% of health outcomes. And so that if we really want to make a dent in improving the lives of our patients and families, that we as physicians and those within mental health care really do need to think about what we need to do to address these social determinants of health. I don't know if this is something that you all face to the same extent that we do here in St. Louis, but racism and discrimination are really important factors in the health disparities that we see and the relationships between the social determinants of health and those inequities that we see in health outcomes in different populations here in St. Louis. So I think that it's important to acknowledge that really when we think about all these different social determinants that underlying them and underlying why there's an unequal distribution of these social determinants of health, often it is racism and discrimination. When we look at folks who report whether their local community are facing some health issues related to these social determinants, you can see that minoritized groups report higher levels of social determinants of health, although even a majority of those who self-identified as white also have report that their communities are facing these social determinants as well. Now, this figure here, I like because it really starts to the left of thinking about socioeconomic status and what's involved there. And if you think about the things that are in red, those red arrows are those that are amplified by racial biases. So if we start off with socioeconomic status, and then we look at the social determinants of health that kind of emanate from that, you can see it's very complex figure with lots of arrows going lots of different directions because these are so highly interrelated. But a good proportion of them are indeed amplified by the racial biases and structural racism that we see in the society, and that they all sort of come together to lead to the inequities that we see in health outcomes. Another way to visualize this, and one of the ways that we think about it a lot in our lab, is that socioeconomic status is sort of the hub of a wheel of factors that can interact or on their own lead to increases in psychopathology or poor health outcomes. And so thinking about socioeconomic status, particularly in this country and the disparities there, it's really important when we think about what are the factors that are most likely increasing or exacerbating mental health issues in our populations. As was mentioned, my lab really focuses on the developing brain, and we've been thinking about how best to measure a lot of various psychosocial factors, including SES, as well as stressors that are experienced both prenatal and postnatally on the developing brain, and how they can come together in utero to impact the neonatal brain, and then how they can continue postnatally to impair development and lead to poor developmental outcomes. So early brain development, there really is a lot that occurs. And in the third trimester, we see some of the most significant brain development that we'll see across the lifespan. And this movie here that was constructed from some of our images from our preterm study done by Kara Garcia, who was a postdoc with us at the time, a graduate student at the time, and is now a faculty at University of Indiana University. Really shows not only a significant increase in the volume of the developing brain during the third trimester, but also the complexity of the folding that occurs. And we really believe that because of this extreme plasticity and development, that the immature brain is much more vulnerable to the environment. So that's really looking at the third trimester, but even after birth, we still see a significant brain development. So if you look on the far left at a neonatal scan, at birth, the brain is about 25% of adult size. Very little of the brain is myelinated. But by 1 year of age, we're at 70% of adult size with a lot of myelination and more complex folding occurring. And at 2 years of age, we're at 80% of adult size. So even postnatally, we still see these really significant changes and rapid changes in brain development, again, making the postnatal brain particularly vulnerable to the environment as well. So these figures propose various mechanisms that may be responsible for the transmission of stress or other sort of exposures during the prenatal time period on the left, and then postnatally on the right to the developing brain. And so you see things like inflammatory markers, cytokines, which has become a really burgeoning area of research more recently, as well as things like cortisol, which is something that's been studied quite a lot when looking at how prenatal stressors may impact the developing brain. But there are other things like the gut microbiome as well as the vaginal microbiome that are increasingly being studied as well, and how that is impacting the developing brain. And then thinking about how the environment may be altering the genome through epigenetic changes that occur postnatally is another area. And our lab is studying several of these different mechanisms and trying to understand how they are the link between psychosocial stress or social determinants that are experienced pre and postnatally and the developing brain. So some prior research that was conducted looking at neonates in this first graph here showed that as socioeconomic status increased, cortical gray matter volumes increased as well. And then another similar study that looked at older age groups, 5 months up to 3 years, also showed that those at the highest SES level had the most significant growth in gray matter volume compared to those who had less social advantage. But an interesting, Amy Margulis is, at Columbia, looked at really the impact of poverty measured through the income to needs ratio across childhood, and looking at hippocampal and amygdala volume, and found that really the greatest impact occurred when the exposure to poverty occurred at 6 months of age compared to poverty exposure occurring at 3 or 7 years of age for both amygdala and hippocampal volume. So suggesting that earlier exposure to poverty may indeed be having the greatest impact on brain development. So that brings us to our lab and some of the studies that we have ongoing that are looking at these factors and trying to understand how they impact brain development. So I'm not going to go over all of them today, but I will discuss our preterm study, which is our longest running study, excuse me, which the kids are now turning 14 and 15 years of age. And then a more recent study, the ELAB study, which is looking at the impact of prenatal poverty and stress in mostly full-term infants. And then our CUDDLE study, which is looking at prenatal cannabis exposure. But we do have a whole host of studies that are going on, and we are one of the sites for the Healthy Brain and Child Development Study as well. The demographics of our population, of our studies, I thought was important to highlight. So again, we are recruiting most of our sample from urban St. Louis, which is where our medical center is located. And so it's we have a large proportion of Black patients, many of whom are on Medicaid, a good proportion of whom are below the poverty line. And so that gives you a sense of the likely exposure to various social determinants that our participants are facing. So starting with prematurity, we know that preterm birth is related to poverty exposure. You can see here in this graph that those at the top, the blue line, had much higher rates of preterm birth. Even when preterm birth was declining, although it's no longer, they still had higher levels than those that were had less social disadvantage. Unfortunately, preterm birth rates have been on the rise again, but this is just to show that poverty, that those that are experiencing poverty do indeed have higher rates of preterm birth. One of the proposed pathways that link preterm birth to poverty include sort of starting off in adult poverty here at the top left, and then experiencing the stress from the experience of poverty during pregnancy that leads to both epigenetic changes, inflammation, as well as HPA axis activation, and then preterm birth. And then the premature child, again, who's now living in poverty, again, exposed to toxic stress, having structural and functional brain changes that lead to impaired neurodevelopmental outcomes, and then can start the cycle all over again. One interesting study that I found very interesting because it was really the first one that I've seen that's looked at the impact of racism on preterm birth. It's a well-known epidemiologic factor or result, I should say, that those that are Black or African American have higher rates of preterm birth. And so regardless even of socioeconomic status. And so in this study, they looked to see the impact of racism, or sort of the chronic stress or worry from racism, and how that impacted preterm birth percentages. And they found that it was really among those African-American folks who had the chronic worry about racism, who really had the elevated rates of preterm birth compared to those that don't, highlighting the potential impact of racism to explain why the rates of preterm birth are greater among African-American and Black pregnant folks. More recently, that same group put out a really nice review highlighting how the upstream causes of systemic and structural racism that then lead to the unfair treatment, that then lead to sort of exposures to things that harm health or other conditions that then lead to some of the biological mechanisms that increase the rates of preterm birth. And so I think it's a nice sort of a theoretical way of thinking about the link between racism and preterm birth to explain their prior findings. So we know that preterm birth has a lot of deleterious impacts, and one of those is really on the newborn brain. So if you see here, you've got a full-term brain on the left and a preterm child from one of our studies that was scanned at the time that they should have been born. So really they were scanned at the same time. And I always say you don't have to be a neuroradiologist to see the significant differences in these two brains, not only in volume, in extraaxial CSF fluid, in the complexity of folding, and in the white matter. You can see some significant differences in these 2D MRI images. And then when we took our images, sorry, trying to advance here, but it does not want to. There we go. And we reconstruct them into 3D surface images. Again, you see really significant differences between the preterm children and the full-term infant here. And you also see a lot of heterogeneity and variability among the preterm children in terms of the complexity of folding and sizes of their brain. But regardless, it's really challenging to think how these preterm children may end up like this adult brain here, being able to develop into this really a typical adult-looking brain. What I should mention too is we study very preterm children. So these are children that are born less than 30 weeks gestation. And these are the children that are at greatest risk for psychiatric disorders. We see here a similar study that was in the UK about a decade ago showed that those that were born, very preterm had higher ADHD, emotional, or what was really anxiety, as well as autistic traits, and much greater rates of any psychiatric disorder compared to their full-term peers. What we have learned over time is that there's this what we call preterm behavioral phenotype that's made up of social communication impairments, internalizing symptoms, as well as either attentional difficulties, ADHD, or executive function deficits. And we, as was mentioned earlier, I treat these children clinically, and it is definitely something that is a very common presentation to the child psychiatrist. So we are now studying these children and have been since they were born. This schematic here shows all the time points where we followed these kids. Myself and Dr. Chris Miser is a pediatric neurologist that I run the lab with. We have been working together for a good while on this cohort. And at birth, the preterm children were scanned up to 4 times, but we're going to focus really today on their what we call term equivalent scan. And then a term cohort was also recruited at the maternity hospital that adjoins our children's hospital, and they were scanned at birth as well. At 2, they came back for developmental assessments and social emotional assessments. Age 5, they came back for psychiatric assessment. We're almost done with the 10-year study. And again, they came back for another MRI. And I should have updated the slide. We were funded very recently to renew the study. And so now the very beginnings of the children coming back at 14 and 15 years of age, where we are scanning them again and again, assessing their psychiatric symptoms and the rest of their development. Now, for folks who don't typically scan neonates, I often, get the question of how do you do that? It really is a lot easier to scan neonates than it is to scan children of any other age. That I can tell you, because now we scan 2- and 3-year-olds and 10-year-olds and adolescents, and these are the easiest. We have them fed by their caregiver, they get swaddled, and then they get put in what we call our papoose here, and their air sucked out, they sleep, and they go in the scanner. And we've had a lot of success. We've probably scanned over 2,000 infants to date across our various studies, and by far the easiest stage to scan. When we obtain our images, we really use 2 different main analytic techniques to assess development. So one is functional connectivity, and this is going to be really simplistic for those of you all who know this area, but for those that don't, so resting state functional MRI, we use a sequence that allows us to get what we call a bold signal, and it basically is kind of a proxy for activity in the brain. So if you think of all these little circles as being different regions of the brain, and they are active at different time points, and then we take one area and we say, okay, what other regions are temporally connected with the same region of interest. And then we correlate activity and find that those in yellow are also active at the same time as our seed region. And so another way to look at this from my medical school classmate, Mike Fox, is that those regions in red, the posterior cingulate cortex, the medial prefrontal cortex, are temporally changing in their bold signal over time as compared to those areas in blue that are in almost the opposite, right? So their correlations are in the other direction. And so we use this information across the whole brain to get what we call functional brain networks, which are areas that work together on very similar processes. And so just listed some of those here. I'm sure they are familiar to many of you, particularly the default mode network. So that's our functional assessment of the brain. And it's nice because you can do resting state functional connectivity in sleeping infants. And then we also look at structural connectivity through diffusion tractography. And so this is one of the images here that we get reconstructed. And we've been particularly interested in the dorsal and inferior cingulum, the uncinate, as well as the fornix, because of the regions of the brain that they connect. And with diffusion tractography, we're able to get measures like fractional anisotropy, which basically gives you a sense of this directionality here, as well as mean diffusivity, which gives you sort of the overall diffusion within the tract. So what have we found? Pepper Sear, who's an MD PhD candidate who is about to defend her thesis, has worked with us. And one of the things that she looked at was trying to understand how motor cortex connectivity related to motor skills at 2 years of age. So looking at the neonatal brain and saying, does this tell me how much variability I'm going to see in motor skills 2 years later? And that's what she found. We also looked at the cingulum bundle, as well as amygdala default mode connectivity and during the neonatal period, and found that it was related to social skills, attention, and internalizing symptoms at 2 years of age. So that preterm behavioral phenotype that I talked about. Rebecca Brady then advanced this, another graduating MD PhD candidate in our lab, looking at the cingulum bundle and looking at it regionally, and found particularly the anterior cingulum was related to social skills, as well as internalizing symptoms and attention and executive function at 5 years of age. And then, okay, let's see if this will get this to work. Oops. More recently, Joe Dust, who was a research staff in our lab, but who's now getting his neuroscience PhD, looked at the ventral attention network, along with some of the other cortical networks, functional networks, and found that connectivity between those networks at birth, again, related to social skills, attention, and executive function at age 5 years. And he's working on publishing that now. And so this is just a slide that really summarizes a lot of work that showed us that the neonatal brain can indeed help us understand variability and development several years later. And we're looking at our 9-10 year data as we speak to see if it really goes out that far as well. Now back to one of the main topics of today, though, is really trying to understand how exposure to some of the social determinants of health may be related to some of the variability we see in the neonatal brain. One of the measures that we use is the area deprivation index. And so this is a measure that's freely available, where you can basically put in an address. This is the address of the medical school here at WashU. And it gives you a numerical rating both for national percentiles, or you could do it for within the state, and tells you if that census block is in the most disadvantaged block groups or least disadvantaged. And red is more disadvantaged and blue is least disadvantaged. And it's really made up of several different factors to get that ranking. And it can give you sort of this national percentile. So we have used the area deprivation index and had a talented student, Bruce Ramphal, who's now getting his medical degree at Harvard. He was interested in understanding how prenatal exposure to neighborhood poverty and individual poverty related to connectivity of the developing brain. and did find that neighborhood poverty was related to striatal connectivity, left amygdala connectivity, and medial prefrontal cortex connectivity with the cingulate cortex. And so demonstrating that in our preterm and term population, that exposure to neighborhood poverty did seem to have some influence on the developing brain. And so this figure just gives you a sense of the different structures that we have been interested in looking at because of their relationship to the preterm behavioral phenotype. And we're really trying to understand if this neighborhood disadvantage is leading to, oh goodness, some of the impairments that we see. And so we have found that neighborhood disadvantage was explaining between 14 to 30% of the variance in that preterm behavioral phenotype that we were interested in. We have shown sort of the relationship of this triangle, but we still really, and Bruce, I should say, did find that neighborhood disadvantage did mediate some of the relationships between the functional connectivity of the brain at birth and age 2 outcomes in this population. So again, showing a role for neighborhood disadvantage, explaining how the brain is related to outcome during early childhood. So that is with our preterm study, which is, a highly selected group of children who we know have abnormal brain development or at great risk for it, given their early prematurity. But our other study, our early life adversity and biological embedding study, our ELAB study, is looking mostly at full-term children who are born into poverty. I should say it was enriched for those who were born into poverty, and trying to understand how a whole host of factors may be impacting the developing brain. So we look at poverty exposure, stress during pregnancy, inflammatory markers during pregnancy, as well as the gut microbiome. And then we follow the children, we follow them at ages 1, 2, and 3. And assess their social emotional development. And we also, in addition to getting the MRI at birth, also obtain MRIs at ages 2 and 3 years of age as well, allowing us to understand how all of these factors may interact to impact child development. And I should say that those are all the collaborators on the ELAB study. So one of the first things we did, because we have a lot of data in the ELAB study, is create latent variables, one that we call our social disadvantage variable, made up of the categories there. And then we also had a psychosocial stress variable. And while they are correlated, but not highly correlated, so really, for the most part, fairly independent. And this is in about almost 400 infants that are part of the study. As you can see, a lot of the factors that we assess here really map nicely onto the various categories of social determinants of health. So Regina Triplett, who is a postdoc and junior faculty member in our lab, was first published how socioeconomic disadvantage in our ELAB cohort related to neonatal brain structure. And what you see here is it really is a global effect because it impacted the cortical gray matter, the white matter, the subcortical gray matter, and the cerebellum. So it wasn't regionally specific, or at least when it comes to brain volume. It really was kind of a whole brain effect, that the more disadvantaged prenatally, the smaller the brain volumes at birth. Ashley Nielsen, another postdoc in our lab, was interested in understanding how social disadvantage was related to those functional brain networks that I talked about earlier. And what you can see here is she found that these brain networks were the ones that were most related to social disadvantage. So you have both some sensory networks, but also some of the higher level cortical and executive function networks that were those that were most related to social disadvantage. Dr. Rachel Lean, who's a developmental psychologist in our lab and an assistant professor, was interested in doing something similar, except looking at structural connectivity. And really, again, looking at a lot of tracks that are either related to emotion regulation or executive function. And what she found, again, was that pretty much all the tracks were impacted by social disadvantage, even if you adjusted for the age at scan and for sex, that she found these significant relationships between social disadvantage and structural connectivity as well. Now, more recently, Dr. Lean's been looking at how the neonatal brain connectivity is related to executive function at 2 years of age, and looking at these some of the same networks, structural connectivity as tracks, as well as some of the functional networks, and did find relationships between both social disadvantage as well as executive function with these networks and tracks. Now, she didn't quite find a mediating relationship. We're still trying to work through some of this data and understand how these relationships are occurring, because right now it almost seems like there's some sort of independent relationship, but we think it just is because the variance that's explained by social disadvantage is so large, and that the variance that's explained by each individual brain measure, is a lot less than that, but it's still likely that that these are one of many different ways that social disadvantage is leading to impairments in executive function. Now, Rebecca Brady, who I mentioned earlier, has been interested in understanding how crime exposure is related to the developing brain. So prenatal crime exposure and functional connectivity of these neonates. So what she did was she obtained crime data for all the census blocks of the participants in our study, and she related them to functional connectivity of the amygdala, hippocampus, thalamus, and default mode network. And this was after controlling for social disadvantage. So many of you all may be aware that St. Louis has a fairly high violent crime rate, but only in particular areas. And so the darker the area, more crime. And so she looked at both violent crime and property crime. Violent crime was more concentrated. There was a little bit more distribution of property crime. And what she found, is that violent crime was related to these particular connections, amygdala, hippocampus, thalamus, anterior default mode network, and also that psychosocial stress, that other latent variable I mentioned, that's made up of depression, anxiety, trauma, exposure, and stress from racial discrimination, partially mediated the relationships between violent crime and the connectivity that she was seeing in the neonatal brain. So again, really important to explain that this was after she controlled for social disadvantage. So this is after you think about poverty, there's an additional impact of being exposed to violent crime on the developing brain. And so this is with the caregivers being exposed to crime during pregnancy, and then the later impact. And so more recently, she's been looking at trajectories of violent crime exposures in the families. And most folks had either very, very similar levels of violent crime exposure across all the time points that we looked over the first 2 years of life. There were some that had some change, but not nearly as many as compared to those that were pretty stable. So then when she looked at the impact of violent crime on externalizing symptoms at age 2, she did find a relationship, not surprisingly, between violent crime and externalizing symptoms. She did not find an interaction between crime and time. So because most of the folks had pretty stable crime exposures over time, they didn't move that much. It really was just exposure to violent crime during the prenatal period. That was the strongest predictor. And then amygdala thalamus connectivity was also related to externalizing symptoms. All right, so the ELAB study really focused on poverty and stress exposure, crime exposure. But one of the other things that's happening now, at least I know it has been legal for, I believe, a long time in California, but in Missouri, recreational cannabis use just became legal in February. So, but even before that, we know there's been a trend nationally of increasing cannabis use prenatally. While other substances have been decreasing over time, cannabis use has been increasing over time. And it does tend to be higher among women who live in urban areas. And a lot of folks who use even early during pregnancy continue to use throughout the pregnancy because they believe cannabis use is relatively safe. Now, the potency of THC in cannabis has increased dramatically over the last 20 years. I have tripled here, but we think now it's 4 to 5 times as high as it used to be. So the prior studies that looked at cannabis use prenatally were looking at really a whole different exposure level than what we're looking at today. We also saw that cannabis use during pregnancy increased during COVID. So this is kind of the most recent data that I could find, but so it's definitely something that is continued to escalate. Now, a lot of the data that we have that relating cannabis use prenatally to development has, like I said, it's older data or it's animal models. But what we have seen is that there are effects on the placenta, and that those effects can lead to things like growth restriction and can lead to low birth weight, which we know in and of itself has an impact on offspring outcome. But we really do need more current studies. Now, Yasmin Hurd is kind of really one of the foremost researchers, particularly from a basic science standpoint and understanding how prenatal cannabis use impacts the developing brain. And so shown that it's impact gene expression, cell firing, and neurotransmitter release, and then related to behaviors in the animals. And then when we look at where cannabinoid receptors, this is focused on the cannabinoid 1 receptor, is across the brain, we see that it's in a lot of the areas that we know are important for psychiatric illnesses: hippocampus, amygdala, medial prefrontal cortex, insula, posterior cingulate. So it's, I think, a really important research question. And then when we look at some PET scans, again, that in adult humans that show where there is binding to CB1 receptors, again, you see a lot in those kind of very similar areas to what is shown in the graphic figure over there. So all of that just to say that we really believe it's important to study what impact, if any, prenatal cannabis use is having on offspring brain development and behavior. And so this is another collaborative study, and we've recruited pregnant patients during the first trimester and obtained both self-report and urine drug screen information on substance use. And then we're also looking at delivery and pregnancy complications and a lot of psychosocial assessments. And then we're scanning the infants at birth and following them at 6, 12, and 18 months. And so this study is ongoing. It's called the Cuddle Study. I did not name it because I'm not creative, but my co-PI, Arpan Agrawal, is. So that's where we get it from, and it is purposely misspelled. So I'll just show you some preliminary data that we've got in our first 90 infants or so. The goal is to scan 250 infants, but we're enrolling 400 folks, and we're at about 330 because just to look at pregnancy complications in the first 400, and then follow 250 long-term based on whether they use cannabis or not. I should say that the folks that we enroll, everybody has lifetime use of cannabis. And the cannabis users who are using during pregnancy cannot be smoking tobacco, or using any other substances of misuse. So we're really trying to isolate the impact of cannabis. So what you see here are some case control comparisons. And what we found, if you look at the areas that are red and orange, these were areas where we found differences in that diffusion measure I mentioned earlier that looks at white matter development between those who use cannabis and those who don't. And when we looked at specific tracks, we also again found that it was those same tracks that we've been really interested in, the cingulum, the unstant, and the fornix, where we were seeing a lot of these differences. So like I said, this is preliminary data, but at this point, we're seeing a bit of a signal when it comes to the structural connectivity of cannabis. And then when we looked at functional connectivity, we're really interested again in those areas that have a lot of CB1 receptors. So the amygdala, the hippocampus, and the cerebellum are some of the ones we've been focusing on. And we found some differences in connectivity. These areas that are sort of yellow to red are areas where we see differences in connectivity between cases and controls. So those that had cannabis use during pregnancy compared to those that did not. And again, we're seeing a lot of, we see some areas around the central sulcus, motor areas, but also some prefrontal regions, temporal regions. But these are early days and preliminary data, so more to come. So that's been what we've done from a research perspective to try to understand how these social determinants of health impact the developing brain. Now I'm going to briefly talk about some of the clinical things that we're doing to assist the patients that we serve and on our medical campus with some of these social determinants. So one of the things that I did sort of concurrently with establishing my research lab was I started the perinatal behavioral health service back in 2012. And this is a service that serves pregnant and postpartum patients. Okay, I unmuted because it looked like I was muted for a second. That serves pregnant and postpartum patients in our community with these mission, vision, and values sort of underlying the care that we provide. It is a growing and large team. I co-direct it with Dr. Shannon Lenz, who's a psychologist here. And then we are sort of split into teams across our children's hospital and our general hospital where our maternity floors are. And then we have our psychiatrists who provide psychiatric care to the patients that require it. And we also take referrals from the community. So to give you a sense of the various units that we work in, these are our inpatient units, both at the Children's Hospital and the adult hospital. And then we're also co-located in our OB clinics. And we jointly started with our obstetrician colleagues, a perinatal substance use clinic. And then again, as I mentioned, we take referrals from our local community. So I should say with the perinatal behavioral health service, in addition to providing care, we also do things like we have part of our local diaper bank. We have a food pantry and our clinic that we started. We provide transportation to medical appointments, and we provide referrals to a whole host of local agencies where we have a lot of really close relationships and are part of a larger perinatal behavioral health collaborative. Now, on the child side of things, we were fortunate to recently receive a philanthropic donation from the Herman family to start the Herman Center for Child and Family Development. And so the Herman Center, the goal of the Herman Center is to take evidence-based interventions and to really study for whom they benefit the most and when. And to do that with populations here in St. Louis that don't generally have a lot of access to care. So we have an infant core where our perinatal behavioral health service, as well as another NIH-funded study, are really focused on providing preventative care to those that are pregnant or postpartum. And then we have a childhood trauma core that includes children who have been physically or sexually abused, as well as those who are in foster care, working with our family court here in St. Louis. And then we have our early childhood cohort, which includes both early child parent interventions led by my other executive director of the Herman Center, Dr. Joan Luby, as well as providing psychiatric care for those that are preschool age. And so taken together, this is a sort of a clinical research hybrid where we are providing clinical care, but also conducting research to understand how our interventions are best utilized in the community and for whom they work the best and at what time point. So I definitely wanted to make sure I left time for questions, and looks like I have. So I'll just conclude with the evidence that we have that shows that social determinants impact infant brain development. And there has been evidence that improving some of these social determinants optimize brain development. So I didn't go over all those studies by other folks today, but there definitely are some studies, a lot with EEG, but that show that If we improve social determinants, we can improve brain development, but we need more intervention research like that, particularly with prenatal populations and with neonates. And clinical programs really can, and they should, in my opinion, address social determinants to improve health. So it's not really enough sometimes in the populations that we serve anyway to only provide mental health care. If we're not addressing social determinants, we can't really get our patients better. And I really believe that mental health advocacy should include advocating for policies that impact social determinants. We know that these factors are responsible for 75% of health outcomes. And if we really want to improve health, then we need to be advocating for policies that impact those social determinants. So with that, I'll just acknowledge our participants and families, my perinatal behavioral health service team, the Herman Center team, and then this picture here is our lab. So we're fortunate to have a lot of really talented folks that do the research and do the brain analyses. So definitely not a one-woman show. So I'll take any questions, and thank you all so much for your attention.
That was fantastic. Do you mind unsharing, and then we can see all the faces? Great, fantastic. We do have, thank you so much for a very wonderful, comprehensive talk. We do have some questions, and Yvette Guerrero, if you'd like to unmute yourself, you're still on and like to ask your question, go right ahead.
Yes, can you hear me now?
Yes, go ahead.
Never mind. I got completely lost. Anyway, yeah, so no, I had another question as well, but so I was just wondering if some of the variable of, multi-generational family history and prenatal trauma or multi-generation family history of trauma or FAS or anything like that controlled for in the group that you were talking about in terms of worry, African American women who worry during pregnancy and the early prenatal. I was just wondering if that was that variable introduced as a possible, aside from worry and other things, was that part of the mix at all?
That is a great question. I don't recall from that study if that was something that they adjusted for or measured. But I can't promise that they didn't. I know it was something that they talked about, at least to a certain degree, in that review article that came later. But I agree that is an important thing to consider. I think it's challenging to disentangle those things from each other. In that, in my mind, a lot of that intergenerational trauma often occurs in folks who are, it can occur in anyone, but I should say can occur in a higher rate among folks who really are impacted even more by a structural racism that leads to that kind of social disadvantage. But I do think it's an important thing to measure, and something we measure in our studies, but I'm not really sure if they did in that one or not.
Sure, thanks.
Mm-hmm.
I do have another question. Was malnutrition during the first 6 months, or was that considered as a variable in terms of impacting on brain nutrition? Because I'm sure it is. I just didn't see it in the slide.
Yeah, part of the social disadvantage variable, we did get at the healthy eating index during pregnancy, and then after pregnancy, we do send out every 4 months a measure of diet and sort of asking about the infant's diet as well. We haven't looked at the postnatal nutritional information yet. So I think that's a good point when we're looking at some of the postnatal relationships, but we did look at the mom's nutritional status during pregnancy when we were looking at the neonatal brain.
Okay. Thanks.
Mm-hmm.
Great presentation.
Thank you.
Thanks for your question. I have a question. Going back to those latent variables that you discussing and how psychosocial stress, and it was the other latent variable consisted of was more social determinants of health. I was wondering how they're you said they were uncorrelated and so have independent impact.
Well, they were modestly correlated, around 0.3.
Okay. And I'm wondering if you can talk a little bit about how to conceptually understand that mild correlation and how they can be independent, you know, the stress part versus the other pieces. If you can just expand on that.
I mean, in all honesty, it's definitely something that I think conceptually we've kind of struggled with, because in some ways of thinking, obviously the social disadvantage can lead to psychosocial stress, right? But because they weren't as highly correlated as I think we were anticipating, we thought it was okay to look at them independently. And so everything that we've looked at with social disadvantage, we did look at psychosocial stress as well. And one of the interesting things I didn't mention, like a couple of the papers that we published, the one with Dr. Lean looking at the brain, the white matter tracks that's in PNAS. We did do something so we could see if there was an interaction in some way between the social disadvantage and prenatal stress. And what we did is we split the groups into those that were 200% the poverty line and below, and then everyone else. And what we found is that among those that were 200% the poverty line and above, we did see relationships between psychosocial stress and some of the white matter tracks. And I think that kind of was really sort of in line with some other studies that have been out there that have shown relationships between prenatal anxiety and prenatal depression and stress and infant outcomes. But what we found, and what we have found in some of our other unpublished work that we're working on now, is that there seems to be a certain level of poverty or material hardship that just kind of swamps everything else that we measure. And so I think a lot of studies haven't had as many folks in that level of poverty as our sample does, and so haven't really kind of picked that up. And so that's something that we're seeing. Like we have some stuff coming out looking at parenting, and like parenting is, doesn't make the impact that we typically see in those that are in extreme poverty compared to everybody else. Like, so I really, from a social policy standpoint, it really does look like we have to address that social disadvantage, particularly when it's extreme, before we can utilize other factors that can be helpful for folks. So I think intuitively it makes sense when we think about it. If you're homeless, if you don't have any food, like, we can try to help you cope with that situation, but you're still in that situation, and that's a pretty dire situation to be in. And so, teaching you how to parent your child slightly better may not be enough to mitigate like just the massive amount of daily stress that you're facing, and nutritional and environmental exposure, and just the whole gambit. So that's a long-winded way of answering your.
I very much appreciate that answer, and you have the data to change policy, a tremendous amount of data. It's quite remarkable.
We are trying. Joan and I have done the congressional briefing. We are doing, we're doing what we can, because we really do think it's an important message that we cannot ignore child poverty or prenatal poverty and think that we can spend money on doing other things and not address that. So
thank you.
We're trying to get the message out.
I want to pass the mic to Dr. Ann Glowinski. Go right ahead.
So I hope it's not going to create a big echo. It's great to see you, Cynthia. And next time, I hope you're going to be in person.
I will try.
So I'm not going to embarrass you with how proud I am of all the work that you've done since I've known you, but obviously I have the luxury of knowing you since you were starting these connections and relationships and work. And so your body of work is longitudinally very impressive.
Thank you.
And I'm very, very proud of you. I want you to tell me if you can reflect So now, sort of 20 years after maybe conversations we were having about what are blind spots in medicine, like how easy do you think it's going to be to do what Barbara is suggesting? So I think that having images is better for policy, and it's better to have these conversations, but like tell me your thoughts about how easy it is to use science to move the needle on these incredibly important issues.
You know, it's not that I think it's easy, but for reasons that are challenging for me to understand, policymakers seem to be more moved by images of the brain than they do by when we say, you know, the child isn't doing as well. You know, I don't know why that is. And so I don't know if it's something about them feeling like it's less the child's fault or the family's fault or something, if it's something that they can point to some sort of biological measure or something. But as you know, one of the reasons why I got in this area is to move public policy and to make these public health statements. And so I think from what I've seen the field do, the fact that even Joan has become like very, very much into poverty, and she was not into trauma and poverty and stress when I first met her, because that's, you know, I was trying to convince her way back when. I think more people are really really buying this and seeing the importance of it. But I do think that we have to keep pushing and continue to let the science really just support what we all know from a common sense perspective, what should be done. But I do think that it is different. You know, I don't think I would have known, 10, 20 years ago that these social determinants impacted health to the degree that they do. And so now that we know that, I think as people who care about health, we have really no choice but to do that. I think we sort of knew. I remember when we would work at our community mental health center, and we would say like, yeah, like given this prescription for sertraline is like putting a Band-Aid on a bullet hole, like when this person is facing all of these other things. And so we sort of intuitively knew, but I think that it's become much more pronounced. And so I just think by the type of research that I see that's being done, and even the NIH, their focus, I think, the pendulum is swinging from being like super hardcore biological to thinking more about these sorts of things as well. I'm hopeful that we're moving in a good direction from a policy perspective.
Thank you. And by the way, when she speaks in front of politicians, she's amazing.
Thank you, Anne.
I hope you're able to read the accolades and notes of appreciation, Dr. Rogers, in the chat. There are many of them. We have about a couple minutes, and I know there's a question in the chat from Thomas Anders. Are you still available to ask your question? Okay.
Don't see, but I will answer it, and you all can tell him. We do have some measures of sleep. We have a junior faculty member whose K is actually getting both in-home polysomnography and actigraphy on the children, and then we do have measures of maternal sleep as well. And there should be some articles coming out about the impact of these social determinants on maternal, what we call chronodisruption, and how that's impacting the developing brain. So you all can tell him yes.
Fantastic, thank you. We have room for one last comment and one very small question. I'm scanning here. Okay, well, this is probably a good, okay, here we go, 2 messages. No, they're just wonderful, wonderful talk. So thank you. I think this is a good place to end then. This was fantastic, and definitely you're one of those speakers we need to bring back to see what's next, what's in store. I would love to hear policy talk.
Yeah, I'd be happy, love to come. So hopefully, like Ann said, next time I'll definitely come in person.
Thank you so much. And take
Thank
good
you
care,
all.
everyone.
Bye.